챙긴다며. Initially, yes. Before CTI, I suggest you to put the his catheter first. Okay, we have the his there. Okay, then and then across the coronary sinus ostium. Okay, like this, and then from the the annulus side, you can appreciate in the little bit small a, the little big the V here. You see here? Okay. I don't see any. Right. A little bit pull it back until we have the small a. Here. Right. Here. Okay. From the aerial view. So this is a good start point for the CTI ablation. This is the receptive side and here. And on pace 7, 8 or okay. 그리고 이제 PVI check. So after that, after CTI block, we need to check the PVI and also make sure the non-inducibility of any slow atrial tachycardia. That's the end point. Okay. Enter the LA, the plane should be vertical. And then also from the RIPV, you can do the directly little bit clockwise more is the right side. I did the clockwise, not the counter-clockwise. From the, once again, if the afocus insert into the RIPV or the LSPV, you can, without fluoroscopy, you can rotate this afocus to the clockwise, and then this is the right side PV. And then release this deflection curve, and then insert more of the RSPV. And also, after that, little bit deflection, and then counter-clockwise. That's to go to the RIPV. But RIPV is sometimes very difficult to insert because your puncture is a little bit anterior. In that case, once again, you better go to the LIPV first. LIPV, fully deflect, more deflect, and then from here, aerial view, clockwise, clockwise, clockwise. That's the RIPV. That's another way. You can go from RSPV and then counter-clockwise RI, but instead, in case of the difficult insert case, go to the LIPV, little bit diffractable. Not this one, little diffractable, and then clockwise. That usually go into the RIPV. Once you insert RIPV, you better change the fluoroscopy into the aerial view is like this. The cardiac margin is insert. So you can insert a little bit more and then push with the RIPV. I think in the inside LA, you have to rotate and use the long sheaths. Without long sheaths into the LA, very difficult to manipulate. So I prefer to use the SL1 without the agilis or other deflectable sheaths. Okay, this is the fixed sheath. For example, here's the roof. Directly contact from here to here is not easy. Very slippery and very difficult to position and this linear ablation. So I prefer here, insert a little bit more. Insert a little bit more, then curve down. Curve down. Here is the mitral annulus. Almost touch the mitral annulus like this. Okay, more. You can watch the three-dimensional mapping system. So once again, direct approach to roof line is very unstable. So I suggest this direction, insert more. Mitral annulus is here. I prefer to keep the sheath at least 4 centimeter, 4 or 5 centimeter, like this. And then a little bit clockwise, in between the LIPV to the mitral annulus. That area is the mitral annulus. How about the anterior wall? clockwise, and then insert needle the ablation here, here, like this. This is linear ablation, linear ablation. But very difficult to do the RSPV anterior by this direction. I go to the clockwise, and then pull back, continue. So this direction into the LA appendage area is I use the line will be met at the center. That's the easy way to create the anterior line. is our the usual position of the catheter on the fluoroscopy. The RIO 30. Okay. This the one the halo duodeca, the one decapolar at the IRA, and on the quadripolar with the RV. Sometimes we move to this quadripolar to the SVC to identify the non-PP foci like the SVC. Okay, so we this is our common catheter position before the transseptal. Okay, we would like to start. Aerial. This is aerial. You can see the decapolar, the duodeca halo into the CS and cover the RA pre-wall. Okay, and in the middle is quadripolar into the RV apex. Okay, we use for the transseptal. This is the SL16. Many different ways to transseptal. One guide wire and two puncture, but we are performing most cases in the two separate transseptal. Okay. So initially, as you can see, let's see the Cosmo. Okay, the guide wire into the left brachiocephalic vein. Okay, like this. Brachiocephalic vein is like this. Okay, and they follow the long sheath and the dilator. So this is BRT, the conventional BRT one. So if you see, so after we insert the needle into the dilator, I injected the normal saline to prevent some clogging the block, the inside and the dilator. Okay. I don't use the contrast routinely. We don't use the ice or other imaging modality. Only the fluoroscopy guided. So we started from the aerial, the 30, 36, 35. And then drag down like this. Okay. So you will see the one and then second jump here. Okay, like this. Okay. Aerial. So aerial, the needle should be the vertical. Okay. So we have to avoid the anterior rotation. This needle should be the vertical line on the RAO 40 or 45 like this. Okay, and then aerial. Okay, and then you try high the normal fluoroscopy. Okay, okay, like this, and then needle. The needle is okay. I already make sure the blood regurgitation. This is the simple way to do the transseptal here. Okay. If you see the sheath after we take out the dilator with the needle, this is the anterior bouncing and then superior like that. Okay, that's very important. And give the heparin. So heparin, we already gave the heparin before transseptal. Okay, and then another second puncture as the same as the first.
So I don't use the fluoroscopy when I insert the needle until the needle turn to the 4 o'clock. Okay, and then make sure before that, as I mentioned, the inject and contrast. I don't know the normal cell line. Okay, and then break down. So second puncture is a little bit lower and posterior than the first. Okay, the jump is not obvious. Okay. I already insert like this. Okay. So you will see the sheath is initially downward and upward in the swing. Okay, after we remove the needle and dilate. Okay, here like this. I insert and then okay like this. That's very important. So injected through the pigtail 6 French and 26 per second and the 4-second rotation angiograph. Okay. 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 Good. Geometry, I think it's done. Also, I like to make sure the location of the ridge. Array of these here. Yeah. Perimeter, posterior perimeter isthmus area in under RIPV. Okay. So we start with geometry from the RSPV now. Okay. So you can start with any PV, but I usually start the LSPV or RSPV like this. Okay. And then I go the area appendage now. Okay. You can see the electrode laser. In and out. And then touch the roof in between the both superior pulmonary vein. Then clockwise. Here is the clockwise. Is directed to the posterior wall like this. Okay, I touch the posterior wall now. From here, when I go the anterior in the counter-clockwise, like this. Counter-clockwise is anterior. So from the LA, the clockwise rotation directed to the posterior wall, counter-clockwise is anterior. If you can touch here near the septum, the anterior round. Okay. Then near the mitral annulus, you can clearly see the pre-electrogram. And these, and the RSPV anterior. Here. Here. Okay. And, also, I like to make sure the location of the ridge, which is between the LSPV and LA appendix here, and LA appendix and LSPV. There's in between, there's a ridge, lateral ridge. Can I see lateral, yes, lateral ridge area. Perimitral, posterior perimitral isthmus area in under the LIPV here. Okay. like this, clockwise anterior. You can clearly see the PV. Yeah, I like to start from here. Ready? Go. Keep the clockwise rotation. Okay. From here to the all the way to the junction between the RIPV and the roof. I have to keep the clockwise to make the firm contact. So I don't see the PV potential at the ablation. So I move midway the track. And the 20 seconds I move. So now I use the counter-clockwise. So make a contact with the procedural now. Okay, from here. Ready? Go. Done. Potential is eliminate. Okay?
Yeah.
Yeah. So potential is eliminated at this anterior anterior operation. So I'd like to stay at least 90 seconds. This side of isolation. Okay?
Yes.
또 보잖아. 어디로 봐? 아.
First of all, I think is the pulmonary pain trigger. Pulmonary pain, especially muscular sleep, trigger initiate, focally initiate atrial fibrillation is very common. The mechanism of the paroxysmal atrial fibrillation who does not have sufficient substrate change. Why the pulmonary pain can play a role as the initiator, a lot of the debate. I think it's a lot of the factors. For example, inflammation or the myocarditis or the hyperthyroidism, and also the recently the established one of the focal fibrotic cardiomyopathy, and also hypertension or other lot of the risk factors may involved. But I think in the paroxysmal AF, without substrate, the most common mechanism is the pulmonary pain trigger. But secondarily, persistent AF, long-standing persistent AF also, I think is the substrate dependent. Substrate which is mostly caused by the fibrotic change. But recently, some paper mentioned not only the fibrosis, also amyloid deposit. So this scar and fibrosis and the amyloid deposit at both atria, that the play also role as the substrate. Some trigger, the PV and the non-PV trigger interact with the underlying substrate. The result in the multiple wavelet or the single wavelet repetitive activation. That's the very mixed mechanism of the persistent AF and substrate dependent atrial fibrillation. So in patient in the paroxysmal AF, pulmonary pain isolation is the essential part. So for the pulmonary vein isolation, in our lab, initially, after we put the multi-electrode, the ring type, the multi-electrode, and another one is the ablation bipolar. And then the isoprotein bipolar in RA. The anode is the inside coronary sinus catheter. I think it's very small energy, 2 or 3 joule, on the up to 5 energy. The biphasic energy is enough to cardiovert. After cardiovert, we wait, usually 1 or 2 minutes. I think more than 80% of the patient, we are able to see the trigger. So if I see the left side left pulmonary vein on the right side PVI, for example, in case of the left side PVI's trigger, we put the one lasso into LSPV, ablation cast into the RIPV, and the exit blow as well. At least the site of pacing inside PV to see the exit block. Because the reason why we isolate the arrhythmogenic PV first is after the completion of all PVI, I think already time passed at least 30 minutes, 1 hour. So potentially just recur or not. So, and then after that, some case we after that we test again to see the no trigger anymore. That's our endpoint. That's the paroxysmal item. So persistent AF is different. So pulmonary vein isolation first during the AF is the ongoing, and then I think it's less than the 20% of the patient only PVI terminate atrial fibrillation or convert atrial tachycardia, but most cases AF is sustained. So after PVI, we create the 3D mapping, 3D CAPE mapping. CAPE, the setting I already mentioned. So CAPE guided LA ablation first, and then AF sustained, we move to the right atrial CAPE. But in our series, we experienced, and about 75% of the patient after LA and RA catheter ablation, AF terminate, atrial tachycardia or sinus rhythm. So if we have the atrial tachycardia, which can be mapped, the mapping, activation map, entrainment map, and then also we target at least mappable. Cycle length is the longer than 230 milliseconds. We try to map. So in the lab, then the average mean number of atrial tachycardia is at least 2.7. So at least 3, more than 3. Map of atrial tachycardia is the endpoint of the percent AF population. So basically our transseptal puncture technique is the fluoroscopy only, without any other imaging. On the AP view in the insert guide wire in the left brachiocephalic vein, and then followed in the sheath, and then exchange broken bone needle into the dilator and the sheath. After that, we inject the saline to prevent any other clot or other clogging. Then drag down. And after that, the needle usually go anterior rotation because of anatomically. That's the lateral wall of the aorta. And then after we drag down, this another posterior jump usually go into the upper margin of the fossa ovalis. So after that, usually this needle directed just underneath of the muscular rim of the fossa ovalis. If you cross the coronal sinus, that you have the chance to puncture into the aorta. So most should be posterior on aerial view, and the aerial view directed toward the spine. That's the very safe approach to. And then after that, you can inject contrast to confirm, but we you can connect on the but if this is right into the left atrium, contrast go anterior. That means contrast inside LA and then LV first. This is different from the aortic puncture. So make sure the RIO area and the blood safely withdrawn and the blood. And in some case, you can use on RIO view contrast. Usually, I prefer to go a little bit posterior and lower compared to the first one. Okay, in case of the failure of the puncture, the separatory, we use the one guide wire left and then follow the ablation sheath, and then another sheath is follow the one guide wire technique. Yeah, either way. So I used the duodeca, which is hollow, for the coronary sinus engaged from the femur. So once I confirm it should be the free without any curve first. When I touch the RA first on the AP view, then a little bit insert more. Go to the area 30 degree change. Area 30 degree may have the potential to show the posterior, and then I change the handheld is the counter-clockwise rotation like this. Okay, once I confirm I already do the counter-clockwise. This area view. Okay, you have to. Maintain the counter-clockwise. That's very important. That will go to the posterior coronary sinus. Once you confirm, for example, sometimes you need to adjust by the relax, the deflection, a little bit more potential to kinking and RA free wall at this area. Even you rotate many times, this a lot of you grab some atrial myocardium, so very difficult to get out. In that case, how we can take her? In that case, I use the right side jugular vein, another catheter, and then ablation cast. That's the, I think, best way without open chest. We insert by this straight, after we straight, and then once we